So my great pleasure to welcome Professor Ross Baker from the Perth Blood Institute. Ross is a practicing haematologist and clinical researcher. He's been PI on over 125 large international phase 1, 2 and 3 clinical trials, and he's contributed to a change of practice in haematology through his clinical research. So welcome, Ross.
Thank you very much. It's fantastic we're all stuck in Perth and we can hear each other's research. This has been a very impressive morning, and how fantastic it is that people are coming together in Perth to do world-class research. Because I think one of the comments from Peter Clinton this morning, it's not us in the room that are competing in Perth, we're competing internationally, we can do world-class research here, and certainly that's been the basis behind the work that we've done. And I want to give a shout out for university private hospital affiliation. Perth Blood Institute's been doing trials for about 8 years, been first in the world in new treatments for lymphoma, myeloma, haemophilia and von Willebrand's disorder. We've got university affiliation and trying to get space in this area to do world-class research with more than 50% outside the public hospitals is one of the urgent things that we need to look at as well in this setting. And really, I've been dragged into the COVID situation because of the thrombosis risk and the emerging data that this is a different disease from influenza. And I'm very grateful for my co-workers at Murdoch and at Perth Blood Institute to help drive this process. And it really is a coming together of a whole lot of different things. And the common message is connecting with people. And Perth is well connected worldwide with this epidemic. And I was just reflecting on what contributions we've made. Because COVID didn't come, we are still in a very good place to advise. And certainly from the venous thrombosis national COVID response, where the issue of DVT and pulmonary embolism was killing people, very quickly Australia had an evidence-based program that people gave up hours of their time to try and have sensible discussion of what we should be doing, particularly when Victoria had an epidemic that could have got out of control. The second thing was the formation only 2 months ago from the Thrombosis and Haemostasis Society when the vaccine-induced thrombosis occurred. I was just looking through my emails. It was 26th of March we first met this year, and it was very generous of the international community to share before publication what their findings were, what the warnings were, and it's rapidly evolved. It's only 2 months since we've had this understanding, and I think the good thing is that information sharing has saved people's lives who've developed this. We knew exactly what to do, not to use heparin in that setting. The other international collaboration has been very helpful, like the International Society of Thrombosis and Hemostasis, for understanding how thrombosis occurs for a long-standing research interest. We've currently got an NHMRC funded project on platelets, heparin and activation and thrombosis, which is right what's happening now with COVID. So we're very grateful for that support. It's always been difficult to get these grants up in WA and being part of that, but that's certainly been a component of why we're so well placed. For the last 10 years, we've had a large international biobanking. You see there on the right, in Australia, New Zealand and Asian Pacific, looking at a rare disease called TTP. And some of the aspects are very similar to what happens with COVID infection, so we could learn from our experience and international connection there. And because there's no COVID disease in Perth, we've collaborated with Ireland. It's had an epidemic with that research, so we've had samples that we could analyse to make a contribution in this field. So there's no doubt this is the surprising thing, that COVID is pro-thrombotic. There's no doubt about the issue that people die from DVT and pulmonary embolism, not just from the inflammatory activity in their lungs. So the reports vary because of the data collection, but up to half the people develop deep vein thrombosis and pulmonary embolism. And if you develop deep vein thrombosis and pulmonary embolism, you've got a 5 more likelihood of dying from the COVID infection. So the tragedy is people leave hospital after being in intensive care, then die from a pulmonary embolism a week later. So we've learnt that lesson very quickly, that, and it's just like what Toby presented today, that COVID infections of strong prothrombotic drive and prolonged prophylaxis is indicated. One of the things that's still challenging that people are puzzling about is our normal prevention of thrombosis doesn't work if you have severe COVID infection. Why is that so? Still subject to investigation, but we've got some clues that's just come about from our research. But it's refractory to standard anticoagulation. So if you have COVID now, the Australian recommendations is intermediate dose prophylaxis rather than full dose prophylaxis, full anticoagulation dose prophylaxis compared to low dose prophylaxis that we commonly use. We haven't got the answer there, it's just a practical solution to a problem. Arterial disease is also an issue, but even more importantly, which I'm particularly interested in, is the microvessel thrombotic components. And if you look at post-mortem samples, it's not only the lung inflammation, but the small blood vessels are occluded with platelet-rich thrombi, and it's reminiscent of this rare disease of TTP that I've talked about. And this is different from influenza. This is why people have trouble with oxygen delivery when this occurs, because it's not just the lung inflammation, it's also the blood flow, and it's the microvessel flow that causes problems with COVID infection. Now, this mechanism is complex. And one of the things that we've looked at is on the far right side of the slide is this ADAMS 13, an enzyme that breaks down von Willebrand factor and stops the von Willebrand factor sticking to platelets. So when you have a COVID infection that binds to the ACE2 receptor, you have endothelial inflammation, and this whole process sets up of a prothrombotic situation for the patient. And our research is focused on the platelet ADAMS component of this, because we think this is important in the microvessel thrombosis. When you're critically ill, and this is an adopted diagram, there's a number of disease processes. Each have something in overlap. I'm not going, for the sake of time, not going into each detail. But people are critically unwell. They often have thrombocytopenia and coagulation abnormalities. But the paradox is the low platelets predisposes you to bleeding, but the thrombosis is what drives the issue, and anticoagulants or other strategies are required to protect those patients. So the more research we do in this area, more importantly, we'll get better treatments in this setting. This is the ADAMS enzyme that we all have that breaks down platelet von Willebrand factor interaction. So when we have inflammation, ultra-large molecular weight von Willebrand factor that's represented in the blues released from the endothelial wall through the Weber-Palade bodies. And if there's minor trauma to the blood vessel wall, there's platelets occluding that flow of blood. And that's what normally happens if you cut yourself shaving. You want it eventually to stop, but you don't want to have a thrombosis. And that normal process is regulated by this enzyme called ADAMS, which breaks down the large molecular weight von Willebrand factor into less thrombogenic forms. But when you have a deficiency of ADAMS 13, then you have accumulation of blood and platelets and von Willebrand factor through the platelet receptor glycoprotein 1b, and that's when you get microvessel occlusion. So it was very tempting to think, could this mechanism be happening in COVID patients? Just to complicate this story, while we're doing this research, there's not many times clots make the front page of the West. This is the issue regarding the vaccine, and very quickly we learnt that platelet factor 4 is released, and in some of these people that develop an immunological reaction that activate their platelets that cause this microvessel thrombosis. It's extremely rare, but if it happens to you, it's a catastrophic event. And the thing that we learnt is that heparin, which we'd normally use, is not the treatment. And avoiding heparin was something we learned within a few weeks. So when the Australian cases came, we already had that information, and we used other anticoagulants in that setting, and we're still developing the testing. So we've got a test for this. Again, there's a lot of controversy about this mechanism, and people who have negative tests, whether they've really got this entity or not. But it's well accepted this is a pathological mechanism for thrombocytopenia and thrombosis in that setting. And this still got an ongoing debate. And really looking at informed consent's an important part of this process, in that this really rare event can happen. The 50 age cutoff was because it tended to occur in people with other autoimmune diseases, particularly younger women compared to men. And so that's why this recommendation was adopted before that very reason. So this is our research looking at ICU patients, only a small number. There's 23 patients with severe COVID infection. And indeed, we confirmed our suspicion. The von Willebrand factor is extremely high. This is a very prothrombotic endothelial cell perturbation that normally if you have an inflammatory illness, the levels may rise twofold, but with SARS-CoV infections, it's between 5 and 10-fold. That's releasing this very sticky von Willebrand factor that adheres to platelets and causes this thrombosis. And even more importantly, the high molecular weight multimers, which are the most prothrombotic, are consumed in this process, and so subsequently depleted in severe COVID deficiency. And the endothelial cells can't provide enough of that substrate for that prothrombotic process. If we look at the Adams enzyme, this is also significantly depleted, not as much as TTP, but when you look at the release of von Willebrand factor compared to the Adams levels, the ratio is significantly higher and out of control in regards to the response of the blood vessel wall, and it correlates to an inverse correlation between that and the Adams enzyme. What does this mean? It means that this pathway is very abnormal and may contribute to the microthrombi, and that there's strategies to look at Adams supplementation with recombinant Adams that may be useful in this type of setting. And certainly that's the next step of us looking in the test tube, but it is used in people with hereditary TTP. We looked at why the Adams was down, and it's very clear that's not the normal antibody mechanism. We know some of the inhibitors of Adams activity from previous research, and certainly interleukin-6 is high, not surprisingly. Thrombospondin that's released from the blood vessel wall is also high. And lo and behold, platelet factor 4, which is released from activated platelets, is also a potent inhibitor of Adams. So we can see this circle of platelet factor 4 being an important part of a normal immune response that's over-exaggerated in people with COVID infection and may predispose to this prothrombotic tendency. So I'll just conclude that our further research is looking to see the modifiers of Adams and what we can do in the test tube for those critically unwell people worldwide that develop the SARS vaccine. It's interesting that we're, from the patient point of view, being at the coalface with patients with hematological malignancies, and I agree that they're the most vulnerable people. If they develop COVID infection, the death rate is significant. Their response to immune vaccination is likely to be less. And really the patient group has driven the COVAXI study that's soon to be launched in the next few weeks, and I'll be interested to talk with the other areas in that sort of setting. But more importantly, this is a general practice-based study because GPs, not or not, are giving the vaccines. Why should we wouldn't we be including them in research for this very important area to look at both normal as well as people with haematological problems? So thank you for the time and invitation.
Thanks very much, Ross. If we have no burning questions, we'll probably keep going, unless we have one very quick one.